can I just first of all suggest that if anyone, any table has specific questions for Professor Anthea Tinker, that we deal with those first because she has to catch her flight. So, and we just
thank you, Judge.
And we address those questions first. Yeah.
I'm the facilitator for table 14.
Yes.
The citizens at this table had two questions, one of which does relate to Professor Tinker.
Yeah.
You discussed the models in the Netherlands. The question from the table is, do we know what percentage of GDP they spend in Netherlands in the care for their ageing population? And as an adjunct to that, possibly for Pat Healy, do we know what they spend in Ireland? We do have another question, Judge, but I'll hold.
Yeah, hold and we'll deal with that one.
Well, I'm sorry to be, can you hear? Sorry to be so unhelpful. No, I don't. I think it is roughly the same, but don't hold me to that. So I'm really sorry, I don't know the answer to that.
Yeah.
I could say, so it's 1.5 billion euro we spend on older people. I don't know the percentage that is of GDP, but that's a calculation can be done. But we spend 1.5 billion in the health service net on older people services.
Thank you.
I am the facilitator for Table 13. There are several questions from the table, but just to focus on the ones from Professor Tinker, the question is, it was mentioned that Dublin has a very good strategy for dealing with old people. What exactly is that strategy, or is there more information available as to what that strategy is? Thank you.
I don't know personally. I haven't done an evaluation, but I did my homework and I printed it out. And there is a whole lot about this Dublin age-friendly city, which is a strategy from 2014 to 2019. And it shows the 5 areas and what they're all doing. So I'm not an expert on it, but there is quite a lot on the web about what they're doing, Dublin's doing. So maybe somebody could do some homework in the Secretariat and let you know.
If I could say that like the age-friendly city, there's Dublin and a number of others. The Atlantic Philanthropy were involved with a whole process which gave rise to the age-friendly city thing, and Kilkenny, there's a whole range of cities now.
County Louth.
County Louth, yes, was the first, yeah. So there's quite a number in that process now, and each of them have a strategy.
Yeah. It's something we might be able to address tomorrow. We'll think about it. Patricia? Yeah, we might be able to give us some enlightenment on it.
Good afternoon, Judge. I'm the facilitator in table number 2. The citizens would like Professor Tinker maybe to expand in relation to the work of the World Health Organization in relation to dementia and recommendations thereof.
Yeah, just I was looking up before and I saw that the World Health Organization published a global plan of action on the public health response to dementia for, I think it was a plan for 2017 until 2025. And so wondering, did you know any more about that? Could you expand on that?
I can't speak for the WHO, and I've looked at the report. I haven't read it in detail, but I think it's significant that they are now focusing much more on dementia. Although I have to say that sometimes things are really very trendy to do, and then you get all this wave of interest and strategies and so on, and the other strategies get ignored. But it's not before time that they have focused on it. But no, I think it is good. I know the person who's responsible in WHO for the ageing strategy, and he says how important the increased emphasis on dementia is, particularly with the dementia age-friendly cities. Sorry, I'm not doing very well, am I?
Hello, I'm the facilitator for Table 1. We just have one, or the citizens just have one question for Mr. Healy. With respect to the short film on Nora, who is the first person to call the coordinator, and where will that person be located?
So the idea is that anybody can call. Often it will be the general practitioner, it could be a public health nurse, it could be the individual themselves. But so anybody who's dealing with the individual, the idea would be that the kernel would be the primary care team, and that you'd have a key worker identified. Then if it's a higher level of need and complexity, you'd have a case worker full-time, would have a group that they're dealing with, and that would be the person. And again, depending on the access to service that the individual needs. So say that they have a turn and they go into hospital, the hospital then would be the people who would contact the caseworker. If it's a case that they need more service for some reason or another, or they need adjustments to the home and OT and things like that, again, the caseworker, it could come from the family, it could come from the individual, it could come from the GP. So what you do is that you make it easy for the individual to have one point of contact, and the team falls in around that then, putting the person at the centre. Does that answer the question?
Just in respect of where would they be located?
Usually the primary care, ideally, if you had a fully developed service, you'd have primary care centres where people are co-located, and that's what we're trying to do. And primary care centres are being rolled out, but we don't have those fully rolled out. So they would most likely be in either the GP practice or in the health centre. In future, it will be primary care centres.
I'm facilitator for table 4, and the citizens at this table have 3 questions, if that's possible. I'll give them one at a time. The first is directed at Pat Healy. The citizens at the table would like to commend what they thought was a brilliant presentation, that your analysis was excellent, and they felt that just the solutions you put forward were equally so. And the question very simply is this: what's holding it up?
I'll take that as a rhetorical question.
I don't think it is a rhetorical question. I think he wants an answer. Am I right?
Absolutely.
Okay. Well, I suppose my sense of it is an agreed model of service for the future. So I think, to be fair, if I was to answer it, I would say that the work of the 10-year Committee on Health is actually trying to bring together a model for health service, which this will be a part of. And the key thing for me would be, I would hope that this type of model is central to the vision for the next 10, 15 years. So it's one of the reasons I was suggesting, I think it's important that you may already have made a submission to the 10-year committee and so on. I think the implementation of that plan now, we identified in our submission that just for social care, you need 400 to 700 million euro of investment over the period of the plan, but you need much more than that. I think the other key thing, just to say that, is when I go back to the slides, and I think it's one of your questions, the issue of leadership and the issue of, what we're trying to do is make it simpler, but professionals who work find that difficult because they're used to being specialists in one area, and you're trying them to get people to work differently and collectively, and I think that's a key piece. So leadership, I think, is a key piece as well.
Thank you. And the second question is directed at Dr. Brown. It's very simply that why has the Assisted Decision Making 2015 Act not yet been enacted, in your opinion?
Just the short answer to that, I think, is that I suppose the administrative and bureaucratic wheels tend to grind slowly, but it is very much in process. The commitment is there, and I suppose the positive thing, I understand that the post for the Director of the Decision Making Service has been advertised, and an appointment will be made before too long, and once that is done, I think that obviously the momentum, the whole process will get additional momentum. So that's, I suppose, all I can sort of say on it at this stage. But those things, sadly, they do take time, but there is movement.
Thank you. And just one final question, if I may. This is just at the panel in general. Recognising that appropriate housing and accommodation can be so valuable to older people in terms of their needs. In terms of the provision of something like this, would this be funded and managed as a sub-department or a sub-function of the Department of Health, or would it fall into the whole housing pool and fall into the Minister for Housing's determination?
Well, perhaps I'll take that initially. I suppose to reiterate, the problem that is there at present is that housing is funded under one department, and obviously the health service is funded under another department. And I do believe that that there is some structural change required. Now, I do think that that structural change needs to happen at two levels. First of all, we need to devolve a lot more decision-making to local level. Ireland is probably one of the least, we'll sort of say, developed, has one of the least developed local administrative structures among OECD countries. That's the first problem, and I do think we need to look at that. But in looking at it, I think we really have to address, the funding problem. And I'm not sure how best to do that. But at the moment, all I would sort of say, I think the process of the development process is severely limited because I suppose everybody tends logically and understandably to look at the scene from their perspective and from their budget and from our budget, whether it's a health budget, and what implications that is for our budget. But what I'm suggesting then, I suppose, is we do need to pilot kind of 2 or 3 or 4 new models with perhaps, an integrated structure, and on a pilot basis that government would decide, well, we're going to make funding available as a package, that is not going to draw out of any of the existing resources for either health services or for local authorities. And the funding can be drawn down on the basis of your ability to come up with an integrated housing with care model. So that's the best I can say, but we do need to change, and we need to pilot how best to change the system, because the system as we have it limits the capacity to develop that integrated model.
Can I just add one thing? I'm part of a team with economists who are funded by NHS England, and we're evaluating the pilot integrated care in England. So watch that space. I think we'll be publishing in about, less than a year anyway.
I could just add, I think a point I made, and just to say it again, is that if you look at the British scene and so on, and social care is in local government, health, NHS, there's a lot of health stuff. So if you're looking at integration, I think it's essential that you join the thing up. We already in Ireland have things like the nursing home support scheme in health. I think that's a really good thing. I wouldn't take that away. But what I would do is bring the kind of flexibility that Michael is talking about and Anthea has talked about into the alternative, into the scene as well. So don't throw the baby with the bathwater. Keep what is somewhat integrated and will be better integrated, and add more to that.
Thank you, Judge. I am the facilitator for Table 3, and we have 3 questions. The first question is with regard to clarity of the citizen's role. They ask, what do you all feel is the role of the citizens in what you've proposed, and what can they bring to the process of deliberations? And the second question is, in terms of developing models and schemes, what stakeholders have been brought in from the very initial stages of development? And the examples given were urban planners, architects, and indeed elderly people themselves. And the last question was, has anything been done to develop a scheme whereby students could be partnered with elderly people given the housing shortage? And have they considered the interaction between developments such as creches and housing for the elderly, sort of interactive spaces between intergenerational groups?
I just say, maybe just answer a few pieces of that. So starting at the back first, there's certainly quite a number of initiatives for intergenerational engagement. And so that idea of children in schools in particular participating and engaging with sheltered housing or that type of thing. I think another really important piece is art and the creative arts. I know both of those would be in Cork, there's in Dublin, they're in different parts of the country. So there's a lot of initiatives like that, and I think they can be broadened. I think just to answer the other two, I think one of the themes I have certainly is that the citizen, as an older person, or citizens generally, should be far more central to decision making and in shaping how we do things. So in anything we're doing, even the work Anthea was talking about there, by talking to older people about the design of facilities, look what it can do. So when we started to redevelop 10 years ago, community nursing units, we involved older people in the design. We went to other countries to look at how that could be done better. So I think that's essential. Much more fundamental, I think, is the networks I talked about there, the 96 networks. I think they actually provide a mechanism where you should have a representative mechanism for people to be engaged with. If I look back when I was a director of disability some years ago, we used to have that. And you had a national forum. We currently have a national forum to engage with people with disability. We're developing local connectivity. I think you should, for older people and citizens generally, have some mechanism like that, where you have real engagement. And one of the side co-production I was talking about, that is about engaging and listening. And if I've learned anything over my time in health, it is about more effectively engaging and listening.
Can I just comment before I go? Yes, there are schemes with students who have communal living and then below in the flats it's sheltered housing. And I know from the experience of the medical students I'm personal tutor to, it's worked extraordinarily well. And the medical students will often hire a coach, take the older people out, and the medical students have gained such a lot from the older people. But I don't think any of these schemes have been evaluated. I know anecdotally the views of the students. I do not know what the older people think.
Yeah. Yes, Michael, yes.
Yeah, if I could maybe just pick up on that last point. The concept of we'll say students sharing homes, the bit of limited experience that I have is with adults with an intellectual disability. And while the experience, by and large, of the adults and the students was very positive, there was a major problem then when the student inevitably finished his or her course and had to move on. And that, in a small-scale evaluation that I did on a project, that caused quite a lot of devastation. So that's something that has to be taken into account. While the model worked very well for the period because there was good matching and so on, that was one of the downsides that I think needs to be anticipated and dealt with. Then going back to your first question about the Assembly, what might the Assembly, the Citizens' Assembly do? I would say two things on that. I think, first of all, I think the Assembly has a very important role is, in a sense, to start, and I use the word start advisory, to start that dialogue in terms of what kind of a society do we want for our older population? What kind of care and support do we want to provide for people with dementia and people who become frail and older people who acquire mental health difficulties? And to, in a sense, I suppose, state the aim, state the goal. And then obviously it's somebody else's job then to look and sort of say, well, how are we going to finance that? But I think society has to take ownership for what we want in terms of how we integrate our older population. And I see that as quite crucial. Now, the second point I would make on what the Assembly might do, and this is, the second one is much more simple, I can assure you, it is to get the whole concept of advanced care planning out there and the need for people, to plan for, for their advanced years in terms of decisions, to dialogue with their family about that and to put in place advanced care directives, because you and I very well know that the absence of clarity around that can cause so much confusion and conflict and, I suppose, stress for families. So that's the second thing, and I think that should be a relatively straightforward message to get out there and get into the public discourse.
Yes.
Thank you.
Very good. And Eamon, what would you have a view on that? What the citizens' role should be?
I understood that question to be what contribution could the citizens make?
Yeah.
By your very participation in democracy, starting conversations in society about how we want to age, how we want to live in our twilight years, if you like. So my comments would be much the same as Dr. Michael's.
I'm the facilitator for Table 8. I have a number of questions. However, the citizens at this table have requested that I convey to the Assembly a comment first. The citizens at this table agree with Dr. Michael Brown that more needs to be done, and it's not enough to simply talk about it. The citizens at this table have instructed me to say that they were grossly dissatisfied at the deplorable treatment of carers by the state and the lack of support for them, and that the persistence of this situation severely undermines Mr. Healy's remarks. As for the questions, I do have one for Eamon and a number for Mr. Healy. If I might ask Eamon's question first. Are you entitled to respite hours as a carer, and if so, how many?
Supposedly I'm entitled to 4 weeks per year. I've had one week already this year, and I have another 2 weeks in October. I'll try and squeeze another week, but I can't find anywhere where that is written down in stone for anybody. I suppose I've been lucky in that in order to organise respite, you get onto your public health nurse. She's the person to talk to, and take what you can get, you know, and fight for anything more that you can get. But I'm not aware of anything being written in stone as to how many days, weeks respite you can get. I've been told 4. I hope that answers your question.
For Pat Healy, is there any particular I have a number of questions, I'll just read them all. Is there any particular reason for the increase in people being diagnosed with dementia? Second question, you recognize that older people have difficulties navigating the system. What is being done to fix it? And you've also said that teams are being deployed for groups of 10,000 aging persons. How many professionals are in each team, and what types of professionals? And then as a general question, if home care is the cheaper option, why is that not prioritised?
A lot of questions.
I'll cover those. So if I start from the back first, so home care is prioritised. So currently we have 50,000 people who receive home care, and included as part of that would be base home help and so on like that, and then of that there's about 16,500 who get home care packages. There is at the same time 23,000 people living in public and private residential homes. So we do prioritise. However, we're limited with a couple of things. One is the resource that's there. So one of the points I was trying to make, and I think is relevant to the point that Eamon was addressing there to you in relation to the respite and the treatment of carers. So one of the key things I was trying to make absolutely clear is that we are very clear in the health service that we don't have enough resource to meet the existing demand, not to mind the future demand. So we don't have enough home care to meet the needs of people as we've identified them. We've waiting lists. And there is a lot of unmet need, and there is growing need. So we would certainly be proposing to seek more, but given the state's finances, it can only put so much into health. It's put a lot of money into health, and what we have to do then is prioritise that. So you are into a rationing and a prioritisation. So on the carer side of it, again, I set out there's 20 or 2,000 effectively short stay beds, and it's the short stay beds that are used for respite, that give carers a break and things like that. All of that is separate from the carers allowance and so on, so that's a different thing that's done through social welfare. But on the short stay respite, again, we would see that as under-provided. And so what I was talking about in terms of the continuum of care, it's the mix of home care, short stay beds, and that voluntary support that you provide, like Meals and Wheels and all of that. It's the combination of all that together that meets the need, and we don't have enough resource to meet people's needs currently. That's absolutely clear. The other ones then, in relation to dementia, there's not, from all of the evidence I've seen, and I'm not a medic myself, but all of the evidence from the experts, there's not one identified reason for it. There's a multitude of reasons. One being as well that people are aging and living longer. So I don't have any one reason for that. I don't think any one has been identified. There's a lot of medical papers written on it and so on. But from a planning point of view, certainly one of the key points I was making was that in the next 10 years or so, by 2026, we will have 100,000 people with dementia where there's 50,000 today. So from the necessity to plan, if we don't have enough resource today, and if it's not as well organised as it should be, we certainly need to be planning a different model for the future. There was the one about, just to remind me about, there was people with disability, just remind me, what was that again?
The teams being deployed of groups.
Oh yeah,
of
the
10,000.
professionals of them, sorry, yeah. So in the teams being deployed, the primary care teams would consist of the general practitioners, GPs, public health nurse, physiotherapy, speech and language therapy, occupational therapy, where mental health are co-located. The intention is with, so the community mental health team will be co-located in a primary care centre, and in the larger centres you have dietitians and others like that as well. But in the 10,000 I was talking about, it's really general practice and the therapies are the key. Safeguarding is coming into it now in a significant way as well. That's an important point. So social work will be an increasing dimension of that. Was there any I missed?
I think Michael has some observation on the dementia issue.
Yeah, mine is actually on the cost of home care, and I would, I suppose, strongly caution against the view that home care is cheaper, because it's cheaper for a number of reasons that we haven't time to go into, primarily because very often it's provided on a largely unpaid basis by people like Eamon, and that's not costed in. Now, I mean, there's a huge issue as to how long we'll sort of say that family caring, we'll sort of say presence that is there can be sustained in the long term. And the second point I would make then is that, you know, perhaps to provide home care at the level at which it's required, for the number of people who are required to give them and to cater for the kind of quality of life factors that I referred to earlier, I think would not and could not be cheaper than nursing home care. But that needs to be tested, and maybe Eamon O'Shea might have more to say about that tomorrow.
Thanks very much.
Sorry, I just had two questions. One for Dr. Brown. Just you mentioned when talking about sustainable communities that there were some examples in Ireland of sustainable communities, and I just wondered if you had any more information, or was there more information available about those examples? And then for Mr. Healy, it was just with regard to the ICPOP. I was just wondering what triggers the framework in terms of an older person with complex care needs. Is it that an acute situation occurs and then the framework is kind of kicks in at that point, or is there some other mechanism by which someone comes under the framework?
In answer to the question on sustainable communities, I suppose primarily I put it out there as a concept that has been floated in documents, but probably hasn't been nearly as well developed as it might be. Now, there are some interesting developments, and I deliberately didn't comment on any individual one precisely because I don't know enough about any of them, but there are initiatives by Respond, say in places like Waterford and Cork. There are Cluj initiatives. There is a recent initiative in County Louth. So there are a number of them kind of happening. So, you know, if you would be interested in that, I think would be useful to look at, certainly at the Respond, you know, website and see what they're doing. But my point is that while these developments are interesting, useful and very significant, that there is still, how would I put it, a gap in terms of where they're located, that they're not planned and located within, with sort of say, the normal town sort of village in environments, that there is still a tendency to make them separate and with the added risk of, I suppose, segregation and difference. And I think that's what we need to move away, we need to move away from difference because we're all the same. So maybe if you want to look at the Respond and the Cluj websites. Thanks.
Thanks very much.
Just on the integrated care framework, ICPOP as we call it, really important point we're making is that the framework is for everybody. It looks at the totality of the continuum of service. It's just that we stratify it then, obviously, and in the presentation you'll see 80% of people are living fine without any great risk. And so while they will have access to service, but they just won't need to utilise a lot of service. And what you have then is in the other three, that the top 1% will have the highest level of need and have a lot of complexity. They were the kind of case we're talking about with someone who might have heart failure, dementia, epilepsy, diabetes, comorbidity, as the medics would call it. And so the point is then is what do you trigger? So the point is that at whatever point you need the service, you trigger it. And so clearly someone who has a lot of complexity will be potentially in and out of hospital more, and they would have a caseworker. So the 5% of the people with the higher levels of complexity, we would expect in general to have caseworkers assigned to them, case management. And so it's a stratification of risk and need of the service. But a really important thing is that it's not to say that some are in and some are out. It's that as you move through the life cycle, and we should respond depending on the need you have, and the kernel should be to support you in your community for as long as possible.
Thank you very much. We're coming up to 5:30, and I'll just take one more question, I think.
Thank you, Judge. The second question from the citizens at table 14 would address to the panel.
Yes.
The question emerges in the context of the challenges facing older people, and a key one is the whole red tape. The bureaucracy surrounding schemes like the Fair Deal and the Home Help, which is seen to be a very intrusive type of bureaucracy. Is there an independent agency which can provide assistance to older people to navigate their way through that bureaucracy? And an example in a financial arena would be MABS. Is there any such independent agency in this arena? Thank you.
Is there any analogue of MABS that would assist people?
Yeah, well, maybe if I can take it first. Obviously, SAGE, the SAGE Advocacy and Support Organisation for Older People, that is an organisation that has nationwide availability, and that is one organisation. There are a number of others. There's one in Cork. Then there's the National Advocacy Service for people with disabilities, for people who have a disability. So there are some advocacy organisations out there and that operate independently. And I suppose I should also say then that side by side with that now there's a whole new initiative about a patient advocacy service and there's a consultation running on that at the moment. But there are organisations out there, and SAGE is the one that I would be most familiar about, and they have an emergency helpline as well.
But are there any issues about funding?
Well, of course, because like all NGOs, there's huge issues, about funding, and I suppose, as far as I know, there is a discussion going on between the HSE and organisations like SAGE as to how the funding issue can be, I suppose, resolved. But the SAGE model is based primarily on volunteers, which has a lot of potential, but it's obviously money and resources are required as well. But I think the principles underlying that approach kind of are there, and I suppose it's a question of how that can be best organised and funded.
I think Pat wants to just...
Yeah, so I think on the independent side of it, absolutely, organisations like SAGE and others provide support there. Important to say that advocacy is through the Department of Justice, I think it is. It was the old Equality Department, I think it's in Justice now. So we don't fund the National Advocacy Service. It's run, we in health have developed our own advocacy, and we're trying to support organisations like SAGE and others, and we do that. But I would be a proponent of advocacy services being funded independent of the health service, given that it's trying to be independent of us. We have our role to play, and we continue to do that.
Is there any realism in that, I wonder?
I think so, because the actual advocacy service is there. The National Advocacy Service is there. Yeah. It has resource, and I think it should continue to be resourced. Separate from that, we as an organisation who provide it should be doing the kind of thing we're doing with SAGE and others to support it. I think the other thing is that we have learned the complexity of the nursing home support scheme that we run. really important thing to say is that this is a statutory scheme. We don't write the scheme. The Dáil, the Oireachtas passed the scheme. We have to implement the scheme as decided. What we've tried to do, and we'll just be publishing very shortly, a much simplified, easier to read version of it. And I think we've learned a good bit around that about trying to make it simpler. I can understand, so we have to live with whatever the Oireachtas determines and implement that scheme because it's a statutory scheme. It's one of the reasons I was making the point in my presentation that whatever about dealing with houses and homes and they're expensive and so on, we really do need a simple scheme in relation to, and that's why I was advocating that we would have in the nursing home or in the home support scheme that's developed now, I would certainly be trying to advocate that it would be as simple as possible and as flexible as possible. They would be two of the things, learning from all that we've done before.
Thank you very much. I'm being pressurised to accept another question, am I? The last one.
Thank you. The citizens of Table 9 have a couple of questions. The first one is to Eamon. Eamon, who takes care of your mother and who pays that person when, if you do your 15 hours per week work? And the second question to yourself, Eamon, is did you get any training in how to care for an elderly lady with dementia and how to care for her as her condition progresses?
Sorry, could you repeat the first question, please?
Who takes care of your mother and who pays that person when or if you do your 15 hours per week working that you said you were allowed and still receive the carer's allowance?
I don't spend the full 15 hours a week outside the home. I can do my particular type of work in the home, from the home. So the only time I might need extra care would be if I had to go to a wedding or something down the country. I don't take any other time off, I'm afraid. And that money has to come out of our pocket. Now you do get, there is the carers support grant. It used to be called the carers respite grant. It's $1,700, but if you ask most carers, most of them spend it on taxing and insuring their cars. But to answer your question, it comes from the family, from the individual. Any kind of private care.
So,
and sorry, did I receive any training? I did a course in family carer training with the Alzheimer's Society of Ireland. It didn't include things like manual handling or anything like that, but it was extremely beneficial. And that was provided free of charge. I don't remember paying for it, but it was the ASI provided it, not the state. Does that answer your question?
It does. It does. Thank you.
Yeah. All right. Well, we've had a very, very long, but a very informative day. A very, very informative day, I just want once again to express my gratitude to all of the speakers and to our expert advisory group who are here to assist us. And I'd ask the members to show their appreciation as well.